So, a very good afternoon to all of you. As we welcome all to this particular session on Facets of Impact, the conversation with healthcare change makers. Before we begin, I would like to give a very brief introduction about Musocia to those who are listening us for the first time. So, we are a strategic CSR design and an impact advisory organization. We believe and dream about a society where every actor is socially responsible. And towards that goal, our academy has brought together Facets of Impact conversation series, where we bring forth interesting models of social entrepreneurship, especially those who stand away from the conventional functionings of the society, and each of one which is trying to tackle some unique aspects about the fundamental needs of the society. So, be it livelihood, be it environment, be it healthcare, education, or creating widespread change in the society. So, in the last sessions of Facets of Impact, we have spoken about challenges in education, livelihood, environment, and some of the social leaders who are tackling them. The conversations are now available on your YouTube channel, links of which are available in the chat box for you. So during our conversation, please feel free to open up the discussions in the chat box and ask questions to the panelists, which will be taken up during the question and answer session. So today we have some amazingly inspiring healthcare change makers amongst us who are tackling the challenges in healthcare in India. Uh, I have I have a lot of respect for all of them for the work that they are doing and also for taking out time to be here today. So without taking much of my your time, I would like to introduce a moderator today, very distinguished Dr. Benazir Patil. She is a CEO of SCORE, Society of Community Health Oriented Operational Links for Development and Impact. She brings with her 24 years of field work experience in the field of social development and expertise in policy analysis and advocacy, and also a researcher. She has been part of several qualitative and quantitative impact work, both in rural and urban projects and in other South Asian countries. So she has done specific assignments with World Bank, the EU, and the British Commission, PATH, and the Save the Children. So I am delighted to welcome you all, and Dr. Benazir, I request you to take the session forward.
Thank you so much, Manju. A very warm welcome and a very good evening to all of you. It is indeed nice to see you all, and it is, I think, the need of the day that we need to talk about the healthcare sector and the need for bringing in disruptors who can bring about a change in delivery of healthcare. And very important aspect, of course, I mean, we all are in COVID-19 times, but the very important aspect for, I think, for more than 2 or 3 decades ago, we've been talking is the access to healthcare services. Of course, we've seen a tangent of improvement from one level to the other. We've seen the differences in urban health, in rural health, in infrastructure, in the missions coming in. A lot of things are visible to us, but at the same time, we still feel that today access is still an issue. Like access, if you really define, is the ability to enter a healthcare facility within 5 kilometers from the place of residence or work. Now, while 84% of the government hospitals in India are, as of 2017, are in rural areas, these rural hospitals only hold 39% of the government beds. And on one hand, you see the dichotomy that we have high-tech, state-of-the-art centers, medical centers in urban areas, and at the same time, we see hugely dilapidated structures in rural areas. So when you talk about access, what is it? And then, of course, the first milestone that we have to cross is access, and then only we can come to quality of care. Now, what we've actually seen in COVID is the need that and the preparedness that we should have had for primary health care. And we are realizing that it is time we need to have different ideas, different strategies, different ways of delivering healthcare, as well as bringing in technology for our support. Because Just to give you a very brief example, and of course, our speakers today bring in their experiences and their capacities and the contribution that they've done. But just to give you a very minute example about what school has been doing. So one of our focus areas, which is elderly population, and like we've been delivering care and support to them throughout March, April, May, June, throughout the COVID period. We realized that while we were doing home health checkups and we were giving them multivitamins, we were looking after their health, we were looking after their chronic conditions. Even then, we realized that in COVID, we had to bring in the telehealth initiative, which was not a part of our project earlier. But we had to bring in telehealth for support because it was impossible to reach people and give them that counseling for mental well-being by physically visiting them every day. So there were methods that we had to devise. We had to bring in a lot of panelists who started giving us that support through remote technologies. So this is something that we are already seeing, and it's high time we discuss and we break the ice. But it's also interesting to tell you that the speakers today that we have already gone a mile ahead and have created a system. Of course, in a small way, some of the strategies they have scaled up and they have reached one level to the other in number of years. All that is fine. But can we take it to the next level by bringing in more entrepreneurs, more social development agencies, and of course, advocate to the government that this is required. So I just want you to, understand the speakers that we have with us today. So first, let me introduce Ms. Anjali Joshi. She is the co-founder and director at iDrishti. iDrishti Eye Care offers pre-diagnostic tests, image capturing of the eye, and uses cloud data to connect doctors and patients via video calls. She was a part of the Stanford Seed Transformation Program 2020. Through her desire to help and support people in need, she set up a telemedicine-based primary healthcare center in a village, leading her to co-found iDrishti. Now at iDrishti, she handles design and construction of new units, procurement, supply chain, quality, NABH accreditations, and compliance. I welcome you, Anjali, to this session.
Thanks, Benazir.
Yeah. Our other speaker is Mr. Jagdeep Gambhir. He's a founder and CEO of Karma Primary Healthcare. Karma runs a chain of nurse-assisted e-clinics in rural India. Jagdeep has about 11 years of experience across healthcare and technology organizations. Prior to starting Karma Healthcare, he has worked in Population Foundation of India, Innovators in Health and Goldman Sachs. And Jagdeep is an MBA graduate from ISB and an engineer from NITK, Surat Kal. So I also want to tell you that Anjali also comes from engineering background, and so is Jagdeep. Happy to have you here, Jagdeep. The third speaker that we have is Ms. Priya Sharma. She's the founder and director at Jimmedari Foundation. She's an MBA in healthcare management from IIM Kolkata. She has previously worked at leadership roles with Johnson & Johnson, Abbott India, and Quest Diagnostics. She's also a contributing member in Mission Khushiyan, an aspirational district development project, and is a partner with the Chief Minister of Uttarakhand, My Social Responsibility Initiative, which is working towards improving socio-economic indicators performance of aspirational districts, specifically in Udham Singh Nagar in Uttarakhand. A very, very warm welcome to you, Priya. So from here, I think it is important that we hear the panelists and understand the wonderful initiatives that they have embarked on. May I ask Jagdeep to begin?
Sure. Thank you, Benazir. It's a pleasure to be here. Thank you, New Socia and Manju, for inviting me here. I'll start with a bit of brief about Karma Healthcare, what we do, and then we can have another round of discussion. So we are, as the name says, we work in the area of improving access to primary healthcare in rural India. As all of us in the session know that there is a huge access issue of healthcare. As Benazir was pointing out, most of the doctors are also in urban areas, and people in rural areas many times have to either delay seeking care, or they will end up going to a tertiary care facility when it is too late. Now, how do we solve this problem? Our model was that with technology, we open e-doctor clinics in rural areas. Our model essentially is built on telemedicine, but when we look at telemedicine and digital health, we kind of look at in service delivery around two models. One is that there is a non-assisted care, so in which anyone is using a smartphone, or a telephone, and access to a doctor that is directly from a user to a doctor. Our model is an assisted care model because we probably, our model is largely in rural areas, and we believe that there needs to be a human interaction and a human face to be able to deliver care. So we follow a nurse-assisted care model in which there is a nurse, and the nurse would then facilitate a video consultation between a patient and a doctor. As with our name, we believe that the true solution will be in providing comprehensive primary care. So just by only doctor consultations or having a doctor on a screen probably not be enough to drive impact level change in healthcare. So our model also relies a lot on outreach. We do a lot of it physically, also through digital systems. We have a pharmacy across all our centers. We have diagnostics across our centers, right? The idea is that anyone who otherwise probably is going to a private informal provider in rural India could probably seek healthcare, which is much more quality controlled, much more evidence based, and probably 1/10 or the cost that they are otherwise kind of seeking, right? We believe that it is a big market opportunity. So we are structured as a for-profit enterprise. But I mean, as I kind of say, we are not a startup of India, but we are a startup of Bharat, right? So we have changes and challenges, right, related to infrastructure, human resources, financing, and so on and so forth, right? So that is a bit about us, and happy to share further experiences as we go along.
Yeah, thank you so much, Jagdeep. May I ask Anjali to share more about your initiative?
Thanks, Benazir, and thanks to New Socia and Manju to get all of us together here. So, Disha Medical Services is the name of the company, and Drishti is the brand of eye hospitals we run. We provide affordable and quality eye care in underserved markets. When I say underserved markets, it again comes back to your word you used, access. There are several districts in Karnataka today where there's not a qualified ophthalmologist who can provide services and deliver surgeries like cataract or something else which the people need. So because of this, because of the access, India has become the blindness capital of the world. More than 1% of India is blind, and 80% of it can be treated with it's avoidable blindness. 80% of them are needlessly blind. So this is the basic purpose that drove us to start the company, and so we have a model to cover distributed populations in districts. So at the district capital, we do have a secondary care hospital that can with surgical facilities. And then we have smaller towns which run on either telemedicine, like teleophthalmology, or it is based only on an optometrist. And then we also have mobile eye clinics that go into rural areas, and they have screening facilities there. So we use a combination of all three to cover an entire district to provide eye care there. So when we say affordable, we have price points across the economic pyramid. So if a person, there is an economic pyramid in every small town. It's not that everybody are rich or everybody are poor in rural areas. So if somebody wants a good quality surgery, they can get it at our facility. But at the same time, if there is a low paying or a no paying patient there who's cataract we have diagnosed, we always try to do a surgery either at low cost, or we raise grants to finish the surgery at no cost to the patient. So that is our model, and we have had a lot of impact numbers. So we do measure when we say we are in a social impact venture. Impact KPIs become very important for us. So we do measure how many of our populations came from rural areas, how many of them came at a low cost or a free, no cost surgeries, how many of them were women in elderly patients. Our customer segments, we do measure how many rural old people, above 60, who cannot probably afford their own eye care. So we do have a lot of these impact measurements that we always have at the back of our head. Uh, so this is what makes sustainable. You do charge patients who can pay, who want a higher quality service, but use the same units, use the same surgeons and the same staff to also deliver a low cost care or a no cost care.
Thank you, Anjali. Over to you, Priya.
Yeah, hi. Thank you, Dr. Banerjee and Manju New Socia team for creating a collaborative platform. So we are from Jimmedari Foundation. We are daily based organization. We are working in two segments. One is the rural healthcare development, and second is the socio-economic indicator developments in the aspirational districts. So in the rural healthcare developments, we are basically working on ADCR model, awareness, diagnostics, cures, and referral. In the awareness segment, we are basically working on the preventive healthcare session. So as disease and disability is basically affected by environmental factors and genetic predispositions, I would say the disease agents and the lifestyle choices as well. So we are encouraging and sensitizing the community to take care of their health by ensuring certain preventive healthcare measures. We are educating the people. So for that, we have enrolled the students from the medical college. So the medical students from the streams of nutrition and dietetics, they are basically being enrolled for the education segment. For the primary healthcare segment, we are running the mobile health clinics. For the mobile health clinics, basically one mobile medical van is dedicated to 25 villages, and the selection of village is based on the disease and health stat of that village. So basically, the distance from the PHC and CHCs, the availability of healthcare infrastructure in that village. If there's a need and there's an access to that, then we add that one particular mobile medical unit for that village. So for that also, mobile medical units is basically equipped with the set of doctors, staffs, paramedical nurse, and the complete setup basically to provide a kind of clinical setup in that particular village. So also we are enrolling the village stakeholders, including ASHA and Anganwadi, Gram Pradhans and everyone. So we are encouraging the institutional deliveries with the help of ASHA and ANMs. Also, we are keeping the track of malnourishment and severely malnourished children with the help of Anganwadi centers. We are also keeping track of the anemia into the pregnant women enrolled at the Anganwadi centers as well. Are basically in terms of diagnostics, cures, and referral, we have a team of qualified doctors who basically provide the primary healthcare at the rural doorsteps only. Also, we have enrolled the point of care diagnostics. So basically to manage the disease at the primary stage only. For the referral program, we are in touch with two stakeholders, government stakeholders. One is the RBSK team. This is basically Rashtriya Bal Swasthya Karyakram team. So all the children between 0 to 18 year of age, they are basically being referred for any complex diseases to RBSK team, and we take care of that, and we take the follow-up with the team that our referred patients are being treated on time. Second is that wherever we set up our mobile medical unit, we set up that in collaboration with chief medical officer over there, and we take that regular feedback from the district hospital managers also. All our referred patients are being treated on time or not. Also to measure the outcome and impact of the program. So we are doing it in a two-way. The first way, we are taking the follow-up of the patients enrolled. What is their health improvement stats over there? All the patients has been enrolled. Second is that we are also doing the epidemiology study in collaboration with the different medical colleges. And also we are checking that the burden of disease and disease state in that enrolled villages. So this is our working model in brief right now.
Thanks so much, Priya. But let me just, because all the audience that is here would have this big question in their mind that these are COVID times, and your organization doing so much work historically and have established so much of system along with the public health system. What do you see some of the challenges during the pandemic? How are you managing that?
Yeah, I would say that there's a complete operation and change in complete operation management now, because there is a norm of social distancing. Earlier, we used to set up in the clinic in the village where our doctors used to take that OPD in that village. Now there is a social distancing norm. So we have changed our model. Now we are visiting door to door. So we are doing the thermal screening door to door. So there are two challenges that coming to us. The first is to manage that social distancing and take care of the COVID pandemic. And second is to take care of our routine patients, because there are also season of disease. So right now it's a rainy season. The diseases like malaria, typhoid, all the vector-borne diseases, water-borne diseases are about to come. We know that. So we also need to manage the COVID along with the seasonal disease. So what we are doing that for the COVID, of course, there is no any medicines and vaccines are yet to come. So what we are doing, we need to educate the people and need to make the people aware about this pandemic, and also need to encourage the preventive practices that need to be taken care of in their respective houses and their respective villages. Also, we are also enrolling the people. Are routine patients suffering from communicable and non-communicable diseases. So we need to take our certain diabetic patient, hypertensive patient, they need a routine checkup. So we are following the now door-to-door practice, and we know that what set of patients need what care, because now we are familiar with the geography as well. So our doctors are being taken care of these patients also.
That's really commendable. I have a similar question to you, Anjali, that you have talked about your mobile clinics for eye care, and that too across 9 districts. It's a huge geography. You may be facing a lot of obstacles currently because of the immobility and the challenges of having the healthcare workers coming over and all kinds of passes and everything.
Yeah. So though workers in essential sectors have not been stopped in doing anything, but we have been asked to stop the outreach programs and camps, because typically when I go to a village with our mobile clinic, we screen and treat about 150 patients in about 4 hours. So that's a large crowd sitting together. So at this point of time, we have stopped all outreach activities as we know, but we have already been doing it in several districts now. So the rural areas where people know of us, all of them are seeking healthcare right at our hospitals. So they are coming to our hospitals to seek care.
Okay. And the mobility, in the sense, how do they travel?
The mobility is hugely, so most of these have their own form of transport. With public transport being stopped or very less access to public transport these days, it is becoming a challenge. But typically what we see is rural patients do club their health seeking activity along with something else. So somebody in a rural area does come to a district or their agricultural produce yard, or to seek something else. So typically they club their activities where they go to a district place typically in a week or once a month. That's when they also have their health seeking. And in other than emergencies, everything else is not such a important thing. So they do try to club their activities when they visit the district.
Thanks, Anjali. Jagdeep, very interesting. You talked about the entire platform you have created with regard to telemedicine. And we are seeing the pros and cons. Of course, we kind of waited earlier. But in today's time, telemedicine, the emerging importance is getting endorsed. So what is your experience during the pandemic?
Yeah, so I think we have been working in this telemedicine or assisted telemedicine field for last 5 to 6 years, right? So we know there has been some experiences on this. So when COVID came, so ours actually is a nurse assisted model, right? So while there is a lot of technology, but a patient is actually walking into a physical clinic, right? And the nurse is then actually using the technology system. And then there are other partners who use our technology, but we, I mean, up till COVID, we were not a direct consumer technology platform. So when COVID actually came in, we actually, so some of our clinics are in a place called Bhilwara in Rajasthan. You might have heard it on TV now. It was a hotspot, and then I got a phone call that there are COVID cases around, and they're like, guys, this is probably supposed to come many months away. How is it? This is March, and what are you talking about? That happened, and we said we have screened, or we saw 12 fever cases on the same day. So we're like, okay, maybe we have seen some. So we had to urgently close the clinic because there was a risk on the health worker, right? So while our doctors are all virtual, but it's a physical clinic, there are outreach workers, so we had said, okay, we can't have a risk, and there's so much paranoia around. So we actually closed our clinics for about 20 to 25 days until we got PPs and other stuff. So now our clinics are operational, but we felt also bad because we were closing clinics. This was a moment of telehealth, and people, this is a health crisis, and we can't just close a clinic. So overnight, our technology team, and actually the entire team worked together and upgraded our system to also enable a contactless consult, right? So through which what we said is that if people cannot come to a clinic, they could access our clinical services for whatever limitations that are there through either a telephone or through a smartphone, right? This is rural India, so again, people using smartphone based non-assisted care consultations probably is at least 10 years away, right? So we actually had to create a more telephone based system which was actually used. And then because we had physical clinics, we then supplied medicines through the doorstep. So we wanted to have a more comprehensive service. You cannot come to a clinic, but then we will supply medicines to the doorsteps, right? So that was this. And then we did a lot of awareness activities, right? Because we had there was so much paranoia about COVID, and because it's a digital system, we have so many patient phone numbers on the database, and our outreach team is anyways in at their homes. So we actually quickly upgraded and did a tele counseling kind of service for our existing patients. So that happened. So that actually we tried to maintain the continuity of care. Now that the clinics are open, people still are not really willing to come to a hospital, right? So they're like, if I go there, will I have COVID, right? Which is very, and many in rural areas there is a lack of transportation available. So the contactless model still continues, and I think going forward it will be there. And then our technology was used by so many other, many doctors, hospitals, providers. So before COVID, we had two, other non-profits who were using our tech system. We actually now have 11, right? At scale. Even so that some of it is actually being used in Australia. So, we got a call from some folks in rural Australia which needed a telemedicine or a teleconsult system, again on an assisted care model. So yeah, I mean, it has been very busy, 3 to 4 months, and yeah, but I think fundamental challenges of solving for primary care, COVID or no COVID, right? Is will are still there, and we for whatever our experience have been are really for non-assisted for a assisted model. We believe that there has to be somebody on the other end. Just having a doctor on a computer report is important, but is not sufficient.
Yeah, I so much agree with you because we are working with the elderly population 60 plus in the urban slums, and the first 3 days of the lockdown, it was almost like this I'm talking of 24th, 25th March. It was almost like we have some of our community staff actually staying in the slums. They are from there, and they were like, what is this lockdown? We cannot cross the door of our house. How do we go about? And interestingly, most of the elderly do not have phones. Their children have phones, but they had numbers of some of us, and they started calling. Where are you all? Are you not going to come? We are left alone. I mean, we are feeling insecure, and so it's. And for us, we had no experience of telemedicine, telehealth. We had never thought of that we will ever need this kind of support, and that's how. So it was all an evolution where it was almost like the community officer going, sitting with the elderly, doing a WhatsApp call, making her talk to the doctor, then showing the medication on the phone that, this diabetes medicine she was taking till last week, it's over. For 1 week she has not taken, what is to be done? And then all of that actually evolved, and then we realized that, oh God, even like in a 2 or 5 kilometer arena, we are going to require this telehealth. And it is almost like now it is like established that for 4 months we are doing that, and it's quite possible that any kind of pandemic that comes tomorrow, we will need this kind of support. So and we all kept wondering, if these WhatsApp calls and video calls were not possible, how would we make the elderly talk to the doctor and talk about, where the doctor is telling, Granny, you don't cry, you first relax, just understand you're fine, nothing's going to happen to you, all of us are here. So just giving her that feeler on the phone where she sees the doctor's face, all of that was like really mind-boggling. We had never imagined that we'll all fall into that ever, in urban areas with everything mobile, where you can just, you're staying 2 and 5 kilometers away from the slum. It's all, we never thought that we need this. So yeah, you want to add something, Jagdeep?
No, I'm just nodding.
So coming to that, all of us are facing this question today, that we suddenly learned so much, and it's showing us a different kind of future. Everybody is talking about this new normal and ways of delivering services and all of that. I mean, we talked about ways of delivering services when it came to physiological infrastructure related, support, but healthcare in a different way now that we'll have to imagine, rebuild, and re-establish those processes is something that all of us are thinking about. So I have this question for Anjali, that how do you foresee the use of technology in future, and what vision do you see for your organization in terms of functioning, whether in COVID, post-COVID, or any other pandemic? I mean, we are really uncertain.
This was very interesting because even the just pre-COVID era, we were trying to relook at our basic mission and vision and drishti, and say, I'm really, how, when I say I am there in underserved districts, am I really there? When I look up a map at my state or a district, and I start looking, there is a distance to which people travel to seek healthcare. Like you said, primary healthcare, people would not go probably beyond the 2 to 5 kilometers radius. So if there is a secondary or a tertiary, at the other end of the spectrum, if you go to a cancer hospital like a Tata Memorial in Mumbai, you'll have all over India people, gathering there for their treatment. So, we kind of internalize saying in the company, in a rural area, I think people should have access to eye care within 30 kilometers, and in an urban area, they should have an access to 5 kilometers. In an urban area like Bangalore, it's very easy to do that. But once you go to a rural area, it is very difficult to find providers. So the ratio of ophthalmologists, because I'm talking of only eye care, I can tell this. The ratio of ophthalmologists to a population of 1 million in an urban town like Bangalore is we have about 25 to 30 ophthalmologists per million population. But once you move to a district that is even like 50 kilometers away from Bangalore, it falls down to 2 or 3. So it's 10 times the lack of ophthalmologists in the district. So given that, finding a challenge, it's a huge challenge to find eye care service within 30 kilometers of any given rural India today. So that can only be addressed through technology, like how Jagdeep said, nurse-assisted clinics. Even we have so ophthalmologists are very difficult to find. We are not creating enough if you take the number of villages to the number of ophthalmologists being created today, it is definitely not going to suffice. So we look at the next layer, like when he says nurses, we looked at a layer called optometrists. These are people who are trained after their high school, 3 to 4 years in a diploma or a degree in optometry, and they know how to use some of the devices, they know how to take some readings of the eye, and they know how to relate to the doctor. We started these teleophthalmology clinics in smaller towns where the entire medical history and the eye history is formed, and then the patient is given an appointment. And when the patient walks in, the doctor is already there on a computer, and then the doctor and the patient do have a call. The doctor has seen all the charts of the patient, and then there is a assessment and diagnosis provided over the link. So that really helped us reach into smaller towns where we didn't have access to uh, ophthalmologists. So we really see technology taking this leap forward. And COVID has really shown the dearth of healthcare providers in such areas. So I feel technology like this will be a huge leap going beyond. And because we use the same platform, if the same patient in a teleophthalmology center wants to come to a hospital, his record is easily available for our doctors. So assessment and continuity of care and quality of care is maintained with the patient.
Thanks, Anjali. Priya, what are your thoughts? How do you visualize your work in near future and years to come, considering the changes that you've already made?
Yeah, so looking at the current scenario, we also do feel that it's a necessity of teleconsultation that needs to be enrolled in our existing model. We can say with an experience that earlier, yes, we have that hospitals and the doctors available for our referral patients who are suffering from a step one of the complex diseases. So now the thing is, since the hospitals are already overburdened and most of the patients, they also don't want to visit the hospital amid there's a COVID pandemic panic around and the people wants to be stay indoors. So having that, so what people are doing that they still have their diseases, but they are keeping it that themselves only, and they're not taking that treatment from that specific doctor. So what we need to do that we need to enroll the consultant from specialized consultant from that segment. Example, some of the cardiologists that needs to be enrolled through teleconsultation. Of course, we are also enrolling the portable ECG and the kind of technology oriented diagnostics mechanism that needs to be enrolled into the primary healthcare service delivery model. It is now very much essential and need to be the part of the program as well. So yes, first is the teleconsultation. We felt that need, yes, it has to be the part of the process. So we are in discussion with the different stakeholders to get that enrolled. And second thing, we felt that along with the digitization, there is also need of collaboration with other essential service providers. Like we felt that this amid lockdown and the COVID pandemic scenario, from last 3 to 4 months, we are basically visualizing some of the old age people, those who are staying alone in their home. The family is in different states, or else we have seen that the many migrant laborers as well, those who came back to their home, but now they don't even have jobs because all the plants and industries are closed. So and plus second, they are at the quarantine stage in their respective homes, so nobody is also coming with the help and support for these people. So we need to enroll and collaborate with other essential service providers as well, so that the basic livelihood amenities can be taken care of. It can be the basic rations as well, or it can be the basic healthcare services as well. So healthcare we are providing, we are collaborating with other stakeholders. So yes, digitization and collaboration with different NGO partners is a must need right now. We felt this.
So, Jagdeep, thanks, Priya. Jagdeep, I have this question. How do you see the entire healthcare sector in India? What some of those changes that it will have to imbibe? How do you see? I mean, of course, technology is one of the key factors, but otherwise also.
Yeah. So I think our work is largely restricted to primary care, right? So my answer would be mostly in the primary care space, because I don't know enough about the secondary care space or tertiary care space to comment. But I think the way when we look at and COVID actually has put a lot of focus back on primary care, which is great. In telemedicine, the regulations of telemedicine were kind of laid and cleared out. So which is a big deal, right? Because now many providers and doctors are kind of open to use teleconsult, because earlier there was a bit of a legal gray area around it. So now there are guidelines cleared. So what we otherwise we would have taken 25, 30 years to do it, probably was done fairly quickly. So that will have a change. There is also in the rural areas, I think, with the advent of Ayushman Bharat coming in, I think what will happen is more innovative financing mechanisms for primary care, right? I think the uh, how do one finance primary care at scale is still an unanswered question. There are many models, right, who look at sustainability of primary care, whether it is a single disease vertical or across. So I think with insurance coming in, with linkages to more tertiary care, I think financing of primary care is going to be disruptive, right, because of technology, right? So earlier, when a referral could not have been tracked to a tertiary care facility, now could be tracked, right? And with the national health stack, coming along as well, right? I mean, there will be a lot of changes around those pieces, and I think that will probably solve, for primary care at scale, right? Because scalability of primary care models has been an issue, right? I mean, there are not many sustainable primary care scalable models, right, on the for-profit side, and I think with COVID, with some regulations and with insurance, coming in, I think that probably we will see a lot of innovative models that will probably will come up.
Thanks so much, Jagdeep. So I think it's time we give the audience a chance to ask questions, and I can see that some of the questions are coming in already. So there is a question for Jagdeep from Arunish Paul. The question is there a plan post-vaccine era, in the sense after we have a vaccine for COVID? How do they plan to roll out to inoculate the rural population, and how do they think of the ethical query, who gets the vaccine first? So it's a it's a very broad and vast question. Of course, Jagdeep, if you would like to respond to it, and I'm happy to have the other panelists also respond to it.
Yeah, so I mean, we don't work on the vaccine space, so this is not a forte, but I'll probably still take, right. So if I was to kind of look at how do we, and this is something which we are doing in some of our clinics as well. COVID, there are certain risk parameters, right? So when a patient walks into our clinic, and because we have a lot of historical patient data, Lancet just published that 22% of Indians are at a risk of, having a severe COVID, right? Because COVID has, different stages. I think the plan should be to, look at models that are, probably treating the patients at risk first, or probably treating the patients who probably can spread the disease more. But, there's probably will require a lot of modeling, right, which is done. We don't do it, so I don't know how it is done, but I think I guess that's what I have to add.
So there are again some questions about healthcare being under so much stress, and similarly healthcare NGOs are coming forward and trying to deal with it. So how do we see as both the entrepreneurs, social entrepreneurs and social providers, and also in bits and ways activists also we become at times? How do we see a reduction in healthcare cost, especially for the underserved population, is one of the questions, and if any of you would like to respond to it. Because cost is one very big factor that we've seen in the current scenario, especially when we saw that the livelihood got affected, and people at a time when they also had immobility in front of them, and at the same time when it came to actual need of services, the cost factor also came forward. So
like Jagdeep mentioned, it's the advent of Ayushman Bharat that has taken care of a lot of marginalized and underserved populations to take care of COVID. And Ayushman Bharat has covered all the BPL segments for free care in COVID hospitals. And largely government hospitals and the public hospitals, medical institutions were the first COVID hospitals. The private care came much later into the picture. when the pandemic started, it was largely these public hospitals or medical education institutions which started becoming COVID hospitals. And at all these centers, Ayushman Bharat has done a wonderful job of taking care of the BPL segment. So, but BPL again is defined by that green ration card you hold, and whether you were there in the socio-economic census data in 2011. So, are you eligible for Ayushman Bharat also becomes, because there are a lot of people who live at very close to the border of APL and BPL, and with livelihood at a crisis today, there are a lot of people who still cannot afford the treatment. So, these are the people whom are applying and seeking to government permits, and I think government has put up, at least in the state of Karnataka, pandemic is one of the catastrophic illnesses, and people are getting free care in public institutions.
So one question which is coming from a couple of participants is that how are the priorities of NGO and NGOs' ways of working and looking at the health sector will change. So all of us here, we believe in healthcare service delivery, whether it's eye care or working with elderly or working with the underserved population. How is it going to change our perspective way forward? It's something that everybody wants to know.
Yeah, Dr. Benji, I would like to add here that yes, we are into the primary healthcare system, and we are basically trying to provide the services at those steps and making healthcare services available and accessible for the people in need. I would say that there's an indeed and a greater need of introducing the preventive healthcare structure as well. Yes, there is a need of behavior change as well. The many diseases, especially that comes from the lifestyle choices, many diseases that comes from the disease agents, and then hygiene practices need to be encouraged, and there's a lifestyle modification, enrolling diet and in exercise, and also enrollment of more and more I would say the medical doctors and students into the awareness and education programs that need to be enrolled, because that behavioral change has to be considered on a priority along with providing the healthcare services. This is one of the way we can reduce the out of the pocket cost in healthcare segment. So this preventive healthcare practices should be encouraged, and like us, NGOs like us, those who are working on the ground, I would say that the ratio should be 50-50, rather than the primary and preventive healthcare should run parallel with the parallel importance, rather than focusing on that curing the disease only. The prevention should also be encouraged.
Yeah. There is a slightly different question, but it's very interesting, and I'm tempted to ask all of you. We have a senior doctor who's asked about how do you place Ayurveda and the Ayurvedic practices in the current scenario? Is there a possibility that we will be able to prioritize it in the post-COVID or way forward scenario? Do we see an importance?
Okay. So right now in our existing model, we are working in Uttarakhand, so there are many Ayurvedic universities in Uttarakhand. So those are basically, they have their own set of measures to basically to treat the disease and to basically to have that prevention measures to, so that disease should not come at the complex stage. And they have their own set of practices. We are already started enrolling these doctors and these practices in our process, and we have seen that lot of appreciation, especially from the rural setups, the rural villages, and because they have their older generation, they have this set of ideas that these methods and these things can basically save and prevent the disease to become around at the complex stage. And now looking at the involvement of our Prime Minister's message also, that there's a healthcare lifestyle changes, and there is an improved preventive practices momentum in entire nation, and there's an entire momentum of diet and exercise as well. I would say that people are appreciating. We just need to take a step forward. There is a need and there's a demand as well.
Yeah, I just want to add to Priya's response that we see a great need for this when we talk to our elderly, especially in with regard to diet and with regard to some of their lifestyle changes and practices. And it is helpful for them when we talk about nutrition specifically. So it does hold a priority, but it has to be structurally and systematically integrated. That is very important, because when we see that a lot of messaging is done by government health providers, it does help. And so how do we train them to really do this messaging is important, I think. There is one more question, and of course it's largely for you and Anjali and Jagdeep, that how do we see a telemedicine consultation versus the physical consultation? And of course, in the current scenario, because of immobility, we realize the importance. But do you see there is difference in quality, or how do you rate it? What difference can you really talk about?
So should I answer?
Yeah,
Yes, go ahead, Jagdeep.
Cool. So yes, I think they are apples and oranges, right? I mean, there is absolutely no comparison. I think while it looks like the doctor is consulting, but there is a very I mean, there's a significant difference between a physical and online consult. We do actually have to train a lot of doctors to sensitize to them about how a teleconsult happens, and there are now actually training modules as well that are out there to understand the limitations of when a teleconsult will not work, in what specialities a teleconsult will not work, in what specialities the teleconsult will work, and some of the features and the sensibilities around it, the non-verbal cues which are not as available compared to a physical touch. In terms of evidence and quality, I think the answer is reverse. We, and hopefully, I mean, there are many studies that have also happened, is that, and we do our audits as well, is that, if done properly, there will not be a significant, clinical quality difference between consult, right? But properly is the operative word, right? I mean, that those devices and, the environment has to be available. Technology with AI and machine learning coming in will probably aid the doctor, right? So we have a clinical decision support system in which if a child comes to our clinic, there are probably lesser chances of errors in the prescription with the clinical decision support system than otherwise, right? So that is this. It is difficult to compare, right? Telemedicine also is used for I mean, if there is an emergency, maybe telemedicine might not be as useful, right? In that, and so a comparison is also, I think, it's an apples to oranges comparison, right? I think that's
yeah. And
Yeah, I agree with Jagdeep when he said there is a whole, when we designed our telemedicine platform, we were of course aware of what to do with the platform, but there was a whole list for our optometrists in our centers as to what not to do. You can certainly, these are the conditions when patients do present themselves with these conditions, never ever do this. There is a limitation with a nurse assisted or a paramedic assisted center. So that said, when data is presented in a very methodical way, when we do have all our, for example, we do a visual acuity where there's a vision chart and we know up to what line the patient can read, and then we also have a refraction where they're tested with lenses and we know up to what power, and after the assisted refraction with the assisted lenses and what line they can read. There is a pressure of the eye. So there are these several parameters which an ophthalmologist will consider necessary before even starting to look at the patient. That is one thing. Second, our doctors have always told us, the assessment process starts when the patient walks into the OPD. As the patient is walking in, the doctor is looking at them and it starts at that point. So we were very particular that when a telemedicine session starts, the doctor is already present on the computer and he's looking at the patient walk into the room and sitting into the ophthalmic chair. So, these are the nitty-gritties which can enable us learn better, make it better for the doctors, and also present data in a way where there is evidence for clinical care. But there are cases at the end of the day which telemedicine cannot solve, and we will have to ask the patient to come to a center where there is an ophthalmologist. But what from my experience, we can at least tackle 30 to 35% cases without the patient having to travel to a town where a doctor is present to seek care.
So there are two key questions which I am not able to ignore. One is, there are already, there's dearth of doctors, service providers. If you look at, consider across the spectrum, and if we have to address this particular gap, what is the way out? Or if you club the other question, which is related to it but is of different nature, is that digital service provision is an upcoming trend, but is it limited to this current era, or it will take up, the uptake will improve? Because you have all worked on it in pre-COVID times and you've seen the change happening. But now with the current scenario, do you see that it's going to have a greater uptake, and it will also, help us address the issue?
The current situation has definitely brought about a severe need. It's addressed, it has suddenly become important. It's gained, there is a spotlight on telemedicine because of the current mobility issues and anxiety. If I go to a hospital, will I be infected? So the current need is, yes, telemedicine is getting its spot in the limelight. But from my prior experiences, the trust issues were in a telemedicine setup versus a physical consultation. I feel physical consultation is winning hands down. That is my experience. That said, the population to specialists, or the population to healthcare providers, is always going to be largely very low. The ratio is going to be very low in rural areas. So my bet would be, we have to use technology to walk the last mile and take healthcare services into the rural areas. I would bet on technology.
Thanks so much. So, all in all, I don't know if I missed some of the questions. They kept on coming in on different screens, and of course in the Q&A box as well.
There was one by Arunish Paul, where he has asked, with online classes, the impact of eyesight in the long run. So
right.
I would like to answer to that.
I'll give it to you.
Yeah. So we had seen this even in the pre-COVID era, when we do a lot of school screening programs in government schools in rural areas and in urban areas. Historically, we have seen a 5 to 7% of eye diseases in children, in the school-going children age. But in urban areas, we suddenly saw it peak to a 10 to 12%. This was, in fact, even published as an SLR report at the United Nations Health Forum last year. So we do see an impact of screens on children's eyes that any eye hospital today is seeing. And during the lockdown, there was a huge increase. The lockdown happened during the end of academic season. There were no online classes then, but watching screens just for entertainment or for games did take an impact. And we are seeing a lot of children who are walking into our centers whom we are advising spectacles today. So that is an impact we are seeing today.
So I think we've addressed a lot many questions that the audience asked, and I would personally like to conclude here that we've had this very interesting conversation where you heard of the telemedicine setup and how it really changed the scenario as far as eye care was concerned. I remember having a chat with Jagdeep about the bandwidth, how to put together first, and really when you go to rural areas, you also have challenges of technology and availability of the bandwidth out there. And of course, we heard Priya also about the mobile units, etc. So we kind of understood that while on one hand we were using telemedicine in the past and we were doing teleconsultations, we did realize in the COVID era that we have to reach the service seekers, at the doorstep. So we did have this concepts of home visits by the health workers, and messaging was already happening. But now all the more reason, because we understood that at one point a set of population like pregnant women, we have to reach their homes, And then Anjali talked about the population which is suffering from eye issues, blindness, and all of that. But at the same time, now in COVID, we realize that there are frail, fragile people suffering from non-communicable diseases. There are ones who are elderly, 60 plus. So there is a big cohort that came in front of us, especially in COVID, who needs services at the doorstep, who need services immediately. They cannot be waiting for a doctor to meet by going. Mobility issues. We saw so a lot of things that we really eye-opening incidents plus experiences that we had during this period. So we all need to really look at different strategies of delivering healthcare, improving access, helping the service seeker, improve their health-seeking behaviors also. Because on one hand, when we saw in the COVID situation that they needed services, they were also helpless about it. Where to seek services, whom to talk, how do we address our issue. So all of this is giving us a very clear indication of moving forward, what is it that we should be doing, and how do we deliver services, and what are those disruptions we'll have to bring in, technology being the biggest one, which we've seen in the past. And during COVID, it became very, very clear that we needed this for all age groups and all stakeholders that really need services. So I think I would just conclude here that in today we have a lot of youngsters also attending this session. It's the time for the startups to really come up with more and more ideas, because ideas can never diminish or vanish or end, because every new experience gives us a new idea, and it is important that we experiment it. So I think now moving forward, we'll have to decide what are those ideas that we want to experiment with, how do we want to deliver care, and how we want to ensure a couple of things, that we reach and ensure services specifically for the underprivileged, for the ones who are immobile, for the ones who are disadvantaged. Because if somebody is suffering from a chronic illness or blindness or any of those kind of things which make them immobile, it's important that we reach and provide those services to them, and fill in the gaps that are existing in the healthcare system. And of course, it will, like most of our panelists today talked about, it will have to be a very collaborative effort. It cannot be NGOs working alone or government working alone. It will have to be a collaboration. We already keep hearing about public-private partnerships and varied examples in different missions and programs. But here too, whether in rural or urban, we will have to create more and more partnerships, because each of us bring in a different kind of expertise, but collaboratively, it becomes a very strong delivery system. So I think I'd just conclude here and request Manju to tell us what next she has on her mind.
So I think, I've been listening to this very insightful and very deep discussion that we have been having. And thank you so very much for this discussion today. It's amazing to listen to all of you and the kind of work that you've been doing and the kind of challenges that you're trying to overcome. During this, I think the healthcare sector has been the most impacted, and it's still impacted, and it's going to get impacted in the coming months as well. So it's very, very enriching. It's very positive to hear about the work that you're doing and the kind of path-breaking initiatives that you're trying to bring about. So thank you once again for this amazing set of panelists here today and our moderator, Dr. Benazir Patil. Many thanks to all the audiences for a very engaging session and your very thought-provoking questions which you have thrown to our panelists today. So for us at New Socia, it has been a very fruitful 4 weeks of learning and experience sharing, and we have been listening to some very interesting, very moving stories of social entrepreneurs from across the country who have been working and trying to solve the fundamental challenges of the society in the field of education, livelihood, environment, and healthcare. And as we are today also closing this particular series of which we call as a Facets of Impact, and with this lovely conversation with all of these wonderful panelists. My heartfelt thanks to all of you for being taking out your time and being here, and also to the team New Social Academy who have been working behind in making this happen. For all of us. So please follow us on our social media pages, and we will be very very soon back with more knowledge sessions with another set of stakeholders. So thank you so very much to each one of you once again. And thank you for joining us today. A very good evening to all of you once again.
Thanks,
Thank
Manju.
you. Thanks a lot.
Thank you. Thanks.
Thanks.